Welcome to Healthcare Blind Spots. I'm Vivian Kopsinger-Birchall, your host, and my special guest at the studio is none other than the Permanent Secretary for Uganda's Ministry of Health, Dr. Diana Atwine. Doctor, welcome to the show.
Thank you for having me, and it's exciting to be here in the Action TV. Thank you.
I am so excited. It's such an honor to host a person like you who is really in charge of Uganda's health system. But before we dig into that, I want us to first get to know who you are. So the first question is, who are you and what led you to this career in healthcare?
I'm a physician. I'm a specialist in internal medicine. And my main area of interest when I was still practicing was in infectious disease and immunology. And I did way back so many years, but now I'm more into governance. I'm the what you would call CEO of Ministry of Health. I'm in charge of general management, planning, budgeting, execution of entire health sector in the country, and I've been there for the last 9 years. So my journey has been interesting, but it was more interesting at the time of COVID. That's really when we tested the resilience that we've never really had before. So it has been quite an interesting journey.
Actually, I'll just start there with the COVID journey, since Uganda has taken pride in its response to COVID. What were some of the highlights of that experience when it comes to healthcare, and especially healthcare in our African countries?
When COVID struck in 2020, because our first case was registered on 16th of March 2020. We had been freaked out of the pictures that we were seeing in what was happening in the Western countries and in China, and we were really scared because our system had not been developed to this extent. However, we had to do it because at that time, every country was struggling on its own. So we did not expect much support from, whenever we get epidemics or whenever we get these problems, we always, work with partners. But this time, everybody was struggling on their own. And that gave us really opportunity to discuss and come up with the things that were indigenous to us, because we did not look to other people to tell us on what to do. And I think to the expectation or to the surprise of maybe Western countries, they thought that because Africa, we had very weak systems and we are underdeveloped, but we registered the least deaths, I think, on the continent. We were able to control COVID. And I think the entire 2 years of COVID, we lost about 3,000 people. And it gave us also opportunity to come up with our own messaging. We worked with our structure because the president was the chair of the task force, and we're having regular meetings with the prime minister, and it was a whole of government. For the first time, COVID helped us to come up with a whole of government to work together, but also with the previous experience that we had, the previous epidemics that we had already we had structures up to the community level. So we're able to follow through the people who had COVID and refer them, and use even our hospitals and create isolation centers. And it also, every dark cloud has a silver lining, because honestly, COVID helped us also to equip our hospitals. We have now more ICU centers. We have more oxygen plants that we did not have. So although it came and shook us, system, but it found when we had a very elaborate structure to manage that COVID. It had also, we had previous epidemics, so we had kind of experience in managing but also political will in the country. At the same time, it helped us to galvanize the whole of government. So it was really a good lesson, and because of that, we established more labs. We have now many more labs, and that's why even for the previous the epidemics, and even now when you look at our previous experience and the recent experience of Ebola, we're able to control Ebola in the real time. I don't think there is any country that has experienced that and has been able to manage epidemics. And I take pride that I was at the center of that we were able to control Ebola. In the last epidemic, when we got Ebola, we were able to do genomic sequencing. In less than 8 hours, we broke the world record, because that, I don't think anybody has ever done that. By morning, when somebody died in the night, a nurse, and we took the sample at midnight, by morning, by 7, we knew the type, we knew we had already finished the genomic sequencing. And so that has really helped us to build the structure. We have established labs. We can now deploy mobile lab anywhere and deal with any epidemic in the country. And even we have been supporting our neighbors. Our neighbors, when they got the outbreaks, they called us, and we came in and supported. So we are there. So.
Absolutely. No, you've mentioned something that I think I've heard over and over in the global health space is the structures that Uganda has in place for disease. And you've mentioned COVID, you've mentioned Ebola, but there's also been conversations about the excellent structure for managing HIV. Yes. I think Uganda has been one of the standards. Yes. So you and your team have done an incredible job and are still doing an incredible job. But of course, where there is high scores, there's always room for improvement. Absolutely. So what has that journey for dealing with the different epidemics or non-communicable diseases, what has it brought out in terms of areas that need partnerships for strengthening?
As a country that is growing and it's a growing economy, we cannot say that we have all the resources that we need to deal with the growing number of non-communicable diseases. Right now in the country, we are seeing just a upgoing trajectory of non-communicable diseases, like cancers. Because Uganda now has more, we are getting, I think recently you heard that our life expectancy has increased to 68 and above. And so we are getting more elderly people. And because of that, we are going to see more numbers, even multiply more in non-communicable diseases. Although we still have communicable diseases like malaria, HIV, but it is going down. And we hope that in future it will not be a bigger problem, maybe because of the epidemics, because of the climate change, though that one cannot be ruled out, and it may not be only Uganda alone, but even other countries. But non-communicable diseases is a big burden. And what we want to see now is really to collaborate with a country like US to establish the centers. We've been working with them, actually. We've been working with Hudson. We've been working with Johns Hopkins. We've been working with Cleveland. So we've been collaborating. We have many collaborations that we've been having in the area of sickle cell. We've been collaborating with Texas Children's Hospital. So in pediatric oncology, we've been collaborating with Johns Hopkins in HIV and Walter Reed project. It is a US funded. So we are working on all those collaborations to strengthen the capacity to screen and manage and also research Actually, our main collaboration is in the area of research, because Uganda's Cancer Institute, let me give that as an example. It has been one of the oldest leading centers that has contributed so much to oncology knowledge in the world. Burkitt's lymphoma was first described in Uganda Cancer Institute, and other diseases. Even when you look at even in infectious diseases, we've collaborated with mainly the Americans and also UK to come up with all these diseases, the viruses that we are discovering. We have Uganda Virus Research Institute that has so many collaborations with here, to make sure that we continue to profile the pathogens that you know, with time we predict that will be of great importance. So all those are collaborations that really we want to continue to strengthen. And we do believe that we cannot do this alone as a country. So we need collaborations, and I believe now the world has shown that really when we got COVID, that now it is a global village. We are not safe. No country is safe except when they collaborate. So we believe in collaborations.
Absolutely. And then just to piggyback off what you were talking about, the Cancer Institute. So I've been fortunate to have a tour of the Cancer Institute twice, and I've been fortunate to work alongside Dr. Orem, or to partner and collaborate. And he and his team are incredible in terms of, like you mentioned, contribution to research, partnerships to improve, to be really a standard in the region for cancer cures and treatments. But, you know, one of the challenges I have observed, at least as an individual, is limited awareness within the public about the different cancers. And I just came back from Uganda to dealing with esophageal cancer. But what are some of the strategies the ministry has to work in partnership with the community health centers to raise awareness of the different cancers? And of course, we have cervical cancer that is killing women at a high stage, and all the other cancers that have very high mortalities. So,
yeah, it is true that I think our focus now needs to look at the community, and there are 3 strategies that we are implementing. The first one is to make sure that we have community extension workers. The community extension workers at lowest government level, at parish level and the village, they are supposed to go house to house, register people, check their blood pressure, check their sugar. If we find a lady that is pregnant, they are linked to antenatal. Now that way, when these ladies come to the facilities, we are supposed to do cervical screening. We are scaling up that, so screening, but also awareness at household level through the community extension workers. The other thing is we want to make sure that we complete our cancer registry. And that cancer registry gives us the certain epidemiologic picture of which cancers are more predominant in. And then we start focusing on prevention. Even right now, even before we complete the cancer registry, it helps us also to go in the community and to continue to talk about that. We are scaling up the preventive arm through immunization. You know, the biggest, I think the most predominant cancer among the women is cervical cancer and breast cancer. And cervical cancer now, because of now scaling up the vaccination of HPV among the girls at 10 years, 11 years old, we think that in the future, maybe in the next 10 years or 20, once our young old ladies in the community are all vaccinated against HPV, we'll see a lot of cervical cancer come down. We are scaling up also we are working with the Cancer Institute to make sure that we enhance the screening using AI in our facility, because you can take, even where you cannot do, you know, those old methods like colposcopy and cryotherapy and all that, but you can just use I just use simple gadget and you take picture, and if for any suspicious lesion, that woman can be linked to care, and then they do further follow-up. So first, community awareness. Two, complete that cancer registry so that we are really able to know the landscape of cancers in the country. Number three, our community reaching out to everyone in the community and linking them to any suspicious person, and vaccination.
Right.
But also, because also we need to look at environmental factors that are continuously leading to exposures. As we increase the care, as we opening up more regional oncology centers in different regions, so that the people who are already sick can be treated, we need to focus on prevention, because we do believe that prevention is cheaper than waiting for the people to come. And we're also working on school health. School health, we believe that for the future is going to be the game changer in our disease prevention. Because once the young people know that it is important to have regular checkup, then that will be the starting point. The old people now, we just have to keep on talking and then encourage them to go for checkup. But the young people, once they understand that, I think that it will be a game changer for the future.
Absolutely. There's one thing I just wanted to raise. It came up for my previous studies, I focused on cervical cancer. And one of the shocking revelations was some of the things that are keeping women away from screening is they fear to be seen naked. That is keeping the women away. So I don't know whether, you know, as a ministry, that's something that is going to be predominant and trying to find ways to get those women.
You know, in African culture, there are certain norms that are still very strong, and they are embedded into our day-to-day lives, and it may not change just overnight. But as we continue to increase education, because now our population now is more literate, more, you know, we have more awareness. We are interlinked through social media, through, you know, everyone, even in the community, even deep in the village, has a smartphone. They know what is going on. And that interlinkage, that intercultural kind of interactions is helping us to remove some of those strong, the culture is good, but there are certain aspects of our culture that keep people away. We still have people who don't want to deliver in our facilities because they do believe that you have to deliver in a certain way if your baby is going to live, and so to convince that some of the mothers to come to facilities to have checkup, to have follow-up, even immunization. After COVID, you know what happened? Everyone was really talking about how the vaccines are going to kill us and everybody, and now it has become a problem to go to every time. We have 14 diseases we are immunizing against right now. And the latest was malaria, when we introduced malaria vaccine. But I can assure you, we have more anti-vax now than before because of that, from the time of COVID. So all those are perceptions that we have to deal with. We can't run away from them, but we have to continue educating our population.
Yeah, what are some of the ways you think you could work with the communities to kind of remove that stigma toward vaccination?
First of all, school, we have to use the school because these children they have influence on their parents. Secondly, we continue to use the leaders, the opinion leaders. Actually, for example, now for us in our communities, We are using opinion leaders. We are using religious leaders. They are people believe in them. We are using cultural leaders, because the cultural leaders also, if someone wants to go at the tangent on the culture as the limitation, once you bring in the cultural leaders, they are able to alleviate any anxiety or any unknown or suspicious information that they need to trust. So we are using actually all of them. So even when we are mobilizing people for those campaigns, for immunization, for screening, for awareness, we make sure that in our cohort we get all those people, and they are the driver. And apparently, I think after COVID, something happened. They used to abuse us at the time, even when we would say lockdown, everyone would come after us. When we would say we are going to immunize, people were like finishing us. But after that, we saw this negativity towards us, because people thought that we are just conniving with people, maybe with the farmer, to bring COVID vaccines and all that we want to finish. Then we have also these ideas of, they want to kill us, they want to finish us, or they are bringing all these chemicals to finish us. So the best person to convey that message are the leaders in the community. So whenever we use them and whenever we bring them on board and give them all the facts, and then they go and take that message to the community, they will accept. That's how we have managed.
Yeah, this will be an ongoing conversation, but let me pivot a little bit to something more technical. Healthcare is expensive, both for you, the government who are funding it, and also for the patients or the community. Yes. So I know that the ministry is working on a universal health coverage. So in what ways can the diaspora, so since we are now in the United States, it's a great time to pivot into the diaspora contribution to our healthcare system. In what ways can we partner with the Ministry of Health to make healthcare in Uganda more affordable for our family members, for Uganda?
At the moment, we are in the process of coming up with a national health insurance. The consultative process took a little longer because I think the private sector is the one that had reservations, but we shall get there soon. And that once we have the national health insurance, it will be able to help us to reduce out-of-pocket expenditures, first and foremost, for the population there at home. But back to you, the diaspora, you have a lot of opportunities. First of all, apart from the remittances that you take home to support the families and make sure that they are comfortable, one of the things that we expect and we really look forward to working with the diaspora very much is in three ways. The first one is to make sure that when you have opportunity, because we have so many skilled people here, so many experts here, different fields of expertise. Want to tap it to tap that skill so that it helps us to build capacity. So we've been seeing this. Many Ugandans that are here that are very top-notch experts have been coming home and conduct, for example, medical camp. They come with the experts and they do a lot, because you find in the communities some people have diseases and they are not able to go to the hospitals because of the expenditures that are accrued to that. So we have seen over time diaspora periodically come home and they conduct, for example, this medical camp, and they do these sophisticated surgeries that we were not able to do, especially in rural setting. That is a plus for that, for you. Number two, we need to, as now we are strengthening the tertiary institutions of care. We want really to open up so that the Ugandans that have this expertise, if you're a neurosurgeon, if you are gastroenterologist, if you have a vascular surgeon, if you have cardiovascular or intervention cardiology, we want these experts to come home. And we have made now our structure. We have enlarged our structure of health to include all these specialists. And now that we are expanding and building more tertiary institutions, we want the diaspora to come home and contribute and settle and love Uganda and work for Uganda. And we have increased now the pay. So
I was just going to get to that.
We have increased the pay. We have increased the pay. So, and sincerely now, our health workers now are better paid. And when you look at really expenditures here, I believe that even the expert here, if they came to Uganda, they would earn that money, but they would save. The cost of living is very, very, very low. So it is good. So I'm calling upon the experts to come back, and the structure is there. So really we want to bring more experts back home. Lastly, awareness. We want to see the diaspora involved in creating awareness through their people. Because people believe in you. Even when you're here, when you go home, you have a lot of influence. And that education. I can't overemphasize the education. And I know that you have that big role to play.
Absolutely.
And then get us friends, to get us partnerships. Get us partnerships that we can work with to enhance healthcare.
Right. So I'm just going to put you just slightly on the spot about the structures for diaspora to engage with Uganda. Some of the recurring conversations in this diaspora space is that there's a lot of red tape and people don't know how to get in the system because it's so hard. What do you have to say to that?
It is, yes, it is hard because it has a certain set of kind of procedures. But when we have, for example, when we want to recruit specialists, we normally advertise through Health Service Commission. And now we want to open up. Before it was hard, but now because of the structure that we have created these super specialists in the structure, it is much, much, much easier for you now to come in and get employed in Uganda.
Well,
yes.
Which is a great segue into the question. One of the questions I have for you is, as the Permanent Secretary for the Ministry of Health, what are some of the priority areas where Uganda's health system needs capacity?
Our priorities are 5. The first one, we want to strengthen community health because we have noted the countries that have very strong community health systems, and the majority of the people they are at that level want to prevent disease. So if there is any, because as we are training our community workers, we need to equip them. To equip them with blood pressure machines, glucometers, simple gadgets that can help our worker to move, That area is still very, very unfunded. And so if there is any partner that can help us on that's a game changer. Number 2, our priority now also is looking at strengthening tertiary services, specialists, because we don't want to see more people leave our country, go to other countries to get treatment. We want to strengthen medical tourism in our country so that we retain all that money that we are losing to go, India or wherever. We want tertiary institutions to be to handle all those cases, so that even if I chose to go outside, it's just a choice. But it's not really that it is a necessity. So that is number 2. Number 3, human resource. Human resource capacity and training. As we increase the tertiary services, specialized services, we need human resource. And so we really want to focus on training and recruiting the right cadres in, especially in those higher institutions. The 4th is digitization. Information system, because information system now is the thing, and having AI and having telemedicine, so that even in the remotest places, someone can get the best service. Even where we don't have the specialists, we use the power of technology to make sure that we are, and we can link, we can have linkages with some of the hospitals here, and then we have collaborations. Even like now we are in under local maternal and neonatal services. We are working with UK very much. So our hospitals, even we do virtual ward rounds together. We discuss real patients together. So it really bridges that information gap. But also to enhance technology. For example, if I have patients in Karamoja, and if you have telemedicine, even if I don't have a specialist, if I don't have a cardiologist there, but I can get the service of the best cardiology in the country using that telemedicine. So we really want to harness digitization and information systems so that we are able to get in real time all the information that is required, the accurate data for planning, for budgeting, and for the interventions. And lastly is governance. Performance. Performance management. And this year, actually, this particular year, we are focusing on clinical governance. Clinical governance really it looks at the whole efficiency. How do you use the resources? Because we don't have enough. Even now with this, shaky ground of, where we were not sure. Which, in one way or another, it is good, I think. It helps us also to know that maybe we need to build our systems. We need to build internal strength.
You preempted me because I was going to ask.
Yes.
Okay.
It is good. It is good. For me, I think it is high time, because when you have a child and the child grows up, you don't continue treating them as infants. So I think it has also helped us internally to see how do we build efficiencies. And this particular year, that is our focus. How do we make sure that we use resources in the best way to maximize? Uganda, I was reading the report by World Bank. Uganda was found to be one of the, I think in the East African countries, we have been ranked best on efficiency gains. So this year we are focusing on making our services more efficient. Looking at the resources that we have and the demand to provide services, we may not get enough resources, but we must make sure that we use the resources in the most efficient way. And this particular year, we are looking at how we can integrate our services. When I go to the community to talk about TB, I should be able to talk about malaria, I should be able to talk about diabetes, I should be able to talk about hypertension, so that it is integrated. But there was this silo, all the time this one is coming, talk about this, and then this one, that confusion. We are now breaking down all those walls and making sure that we integrate. And we have seen this work. We have really seen this work. And so we are saying, yes, the funding may not all come through and whatever. But I want to tell you, to us, it has been a great eye-opener. It has been great learning, so it is an opportunity for us to continue introducing efficiencies in our operations. And so this year, we do believe that if we implement our strategy right now, we are going to even to see more efficiency. Although they've ranked us the best in efficiencies, because the money and the output we have is way above compared to our counterpart in the region. But we do believe that we still have room to improve and continue to make sure that we optimize the resources. We deal with corruption, because those are things that make our systems weak. So as we continue to provide services, as we continue to plan, as we continue to budget, we need to put money that gives us greater impact, high impact interventions. That's what we are doing this year.
I'm so happy to hear about the integrative approach, because yes, I concur, it's a way to go. But also you talked about the use of technology and artificial intelligence, and yes, that is certainly the way to go. I have seen it, work in collaborations between the United States and Uganda in hospitals and surgical rooms, and you get an expert here who's building capacity back home. One of the questions, though, I would put to you is one of the recurring challenges with this technology is access to connectivity, especially for rural areas.
Yes.
So in what ways are you going to forge partnerships, say, with the providers for internet to expand access to connectivity, not just for the hospitals, but the patients, so that they can, say, access their medical records at home without incurring high expenses? Is that a conversation going on?
It is actually one of the priorities of government. For example, in the strategic plan of the Ministry of Energy, and also our National Development Plan 4, it is a big priority. Power access, because not just internet, power access and connectivity. And I think in the last 5 years, the connectivity has doubled in the country. And that connectivity is continuous, and we do believe that it will not be a big problem in the next 5 years. We will have covered a significant part of Uganda. And the priorities are going to the facilities, the service delivery points, schools, hospitals. And the good thing now with mobile phones, people can access internet. And the penetration is very good in our country. So we don't anticipate that will be a big problem.
All right. This is great. First of all, there is so much I could talk about health, but that would mean keeping you here all day. But maybe as I round it up, I saw the alert system on the Ministry of Health page, and I thought that was an incredible initiative where someone can put in their symptoms, their temperature. So kudos to you and your team for doing that. But in terms of the future, in what ways are you planning for more response, more disease alertness, I guess, because if all diseases are, I know the alert systems usually work for epidemics, Ebola, but then we have, the non-communicable diseases that people need to, to alert, I guess, to gather data on the epicenters of some of these diseases, for lack of a better word. Is there any plan for that? And
for non-communicable diseases, we do believe that through community extension workers, they are able to pick some of those people that are not diagnosed in the community and link them to care.
Okay.
And when we do that, it will help us to detect early and treat and link these people. Because many times why non-communicable disease care is very expensive. Many times people come very late.
Yes.
With many complications. Diabetes, someone has kidney failure, someone has heart failure, and that becomes very expensive to treat. So we think that we strengthen the community level, all the information, so that we're able to know the whole country. Just scanning through, we know how many hypertensives we have, how many diabetics we have, how many sickle cell patients we have, how many heart disease we have, how many. So then it can help us to plan. So, and the community information system, because our community extension workers have the tablets and we have digital tools. When they go to household, they collect all this information. And that information comes directly into our database, and we are able to see each village, each sub-county, each district, how many people have these problems. And so it's more like an alert. It keeps on coming. So that will help us to deal with the non-communicable diseases. Communicable diseases, we have what we call emergency operating centers that we have established in each region. Now, we have a regionalization kind of program. Our EOCs in the region are being manned by our staff. Now, any information that comes from the community the alert come through, whether maybe suspected cholera or any poisoning or any emergency, anything called emergency, it comes through, and we are able to see that in real time as it happens, as it is picked from the community. So that then now we activate. Whenever we get that, then we activate through our structures in the district, in the sub-county, in the village. Then they follow through. So that's why we are able to detect. Many times our epidemics cannot go beyond, even a day. So that we are using it to follow through. But also we have now set up our call center, 24-hour call center.
Oh, interesting.
That even young people who cannot, for example, get help from maybe parents, or because also we still have high teenage pregnancy, we have we want to strengthen that. So we've also created that linkage where people can call anytime for care, for counseling, for being linked to care. So it has also helped. We have established the what we call client satisfaction digital tool. When you go to our facility and you are served, it kind of gives us in real time feedback. So you scan the QR code. It is translated the tool is translated in all the languages in the country.
Oh.
So once you scan, then you put in your comment, whether the service was good, how you want us to serve you better, what are the issues that you noted at the facility, and that information comes directly to us. And we are able to call the people responsible in that area. So that digitization is an amazing way to keep informed. Yeah. So.
Excellent services, and I hope our public is learning as much as I am learning, and figuring out, especially diaspora, figuring out ways to engage with this whole system and process, which is very elaborate. And then maybe one of the final questions is, you as Dr. Diana Atwine, what's your vision for the next 5 to 10 years for the Ministry of Health? And what if I asked for like 3 big priorities for you, what would they be?
In National Development Plan that we have just finished, first of all, we want a healthy population that is productive. And how do we achieve this? We must reduce disease burden. disease burden must be done through our awareness. We think that is really a game changer, and that's, if you've been following that, that is really an effort that we're making. The second thing is digitization and linkage. I'll be able to link with you while I'm in Uganda and you are here, maybe we're in the hospital, and working together so that we bring the partnership into real practice, and that can help us to do more. We need to address health financing, because for a long time it has been still a challenge, but risk pooling is very important, and now I'm glad the conversation on human, especially in the area of human capital development. The human capital development cannot fully be implemented without health financing, meaningful health financing. And we do not see any other apart from making sure that we do risk pooling through, for example, national health insurance, the tax, special taxes for like cigarettes, like alcohol, and all these other, like how other countries are raising resources, because we will not have enough money to treat everyone for free. Government etuyambe. So we'll have to do that, and it is the only thing that we do believe that is going to help us do things our own. We do more instead of waiting for external financing, because we still have about around 40% of our health financing in health coming from from external sources. We want to see 100% financing come from internal revenues.
Yeah, I think that's why I had earlier asked the question about, how the diaspora remittances can be used in some form, whether it's through bonds but just to get toward health financing. And this is because I've been having a conversation with friends around this, just even envisioning Uganda, if there was a model for Uganda's health financing. But anyway, that's a conversation for another day. But I'm so glad that you mentioned, you give us an insight into your vision through those three areas. They are all achievable, that's what I can say, with the right partnerships and the right focus. And I guess one last ask, if there's anything you'd like to tell our viewers, anything that we might have missed in our conversation, please.
Dear viewers, I'm happy to be here in the States, and I'm happy to be here talking about health that is at the center of my heart. I do believe that diaspora, you have a big role to play for the country, and we still need you. But we want you to get friends that can come in the country and invest, because any country that is developing relies largely on how much investment that comes into the country. Bring people for tourism. Uganda has always been the best tourist destination. You don't have to cool air, you don't have to warm air. God gave us everything. The most beautiful country on earth is Uganda. So please come, get friends to come and visit. We are welcoming people, our culture, with diversity, the food, the freshness, everything. Please bring friends to come and visit us. Come home and invest home. We welcome you. Thank you.
And with that, Dr. Diana, thank you so much for being the guest on my show. And to our viewers, I hope you've learned more about what's going on with the health sector in Uganda. You can't have it from any other person than the horse's mouth herself. And I hope that you can participate in improving a health sector. That's if you're diaspora. And any other friends of Uganda who want to join the partnerships, we will welcome you. And you can find the contact Ministry of Health. What's the best way to contact Ministry of Health?
We have a toll-free.
Absolutely. So we'll have the contact for you at the right down here. But for now, thank you for watching. Till next time.
Thank you.